Hi, everybody. Welcome to today's episode of Oncology Data Advisor. Today, we're here with one of our board members, Dr. Matt Hadfield. We just returned a few weeks ago from the ASCO annual meeting, and there was a lot of really exciting data there. And some of the most exciting data was about the NADINA trial in melanoma. So Matt, would you like to tell us a little bit about this trial?
Yeah, no, absolutely. Thanks for giving me the opportunity to talk about this. So the NADINA trial was one of the plenary sessions presented at ASCO 2024, and it's really important for a lot of different reasons. So just to kind of give a little background, in melanoma, and melanoma is cutaneous melanoma is in many ways the prototypical immunotherapy cancer. And we've seen that, it's been used in the metastatic setting, and then it was studied in the adjuvant setting, and now we're seeing more data in the neoadjuvant setting. And essentially, there's been a paradigm shift towards using immunotherapy prior to surgical resection, and that's really based on preclinical evidence and correlative studies that have been done showing that when you give an immune checkpoint inhibitor while the tumor is still in place, both the neoantigens from the tumor can prime the immune system and generate a more robust response. And you have tumor infiltrating lymphocytes as well that are still present in the tumor prior to removing them. So really the big adjuvant neoadjuvant study to really first look at this was SWOG 1801. That was the study in which pembrolizumab, the immune checkpoint inhibitor, was studied in both the neoadjuvant setting for 3 doses and then adjuvant compared to adjuvant alone. And in that study, it was shown that recurrence-free survival was significantly better in those receiving neoadjuvant, PD-1 blockade, as opposed to just receiving it after surgery. So this was a huge paradigm shift in terms of thinking about giving immunotherapy prior to surgery, leading to the NADINA trial, which the NADINA trial was an international phase 3 randomized study. It included 423 previously untreated patients with stage 3 macroscopic resectable melanoma with at least one positive lymph node. And it randomized patients to 2 arms. So the first arm, patients received ipilimumab, the CTLA-4 inhibitor, at 80 milligrams, plus the PD-1 inhibitor nivolumab at 240 milligrams every 3 weeks, followed by total lymph node dissection. And the comparator arm of this study was adjuvant nivolumab alone. And then essentially patients who achieved a major pathological response, which means that there's less than 10% viable tumor cells left in the surgically resected specimen, they received no additional treatment. The others that had, less than or more than that, or failed to respond, then went on to receive 11 cycles of adjuvant nivolumab. Or if they had a BRAF mutated disease, they received adjuvant dabrafenib and trametinib for 46 weeks. And the primary endpoint was event-free survival. So very, very impressive that after almost 10 months of follow-up data, the 12-month event-free survival was 83.7% in the people who had received neoadjuvant IPI and Nivo, and 57.2% in the adjuvant arm alone. And the hazard ratio was 0.32, which is remarkably impressive, showing that there's a very big separation in these 2 groups in terms of the statistical significance. Now, this is really, really big for the field of melanoma, because this is the first phase 3 study looking at dual checkpoint inhibitors in the neoadjuvant setting, and showing that we are having reduced event-free survival. Some of the limitations of the study right now is that we don't have overall survival yet. So we don't know that if we have really great data based on the phase 3 study that 1 year out, the event-free survival is remarkably different. The event-free survival is defined as, death, recurrence of melanoma, et cetera. But, we don't know yet, are patients going to live longer if they undergo this therapy, prior to or after. And the other big question is, there is no randomized data at this point now showing whether or not you can, those who achieve a major pathological response with a single agent PD-1 inhibitor as opposed to the addition of ipilimumab in the neoadjuvant setting, like, do they have the same benefit? And that's likely not a study that's going to happen. So there's a lot of questions about how this affects our management. And I think one of the biggest things about the NADINA trial that is important for everyone to keep in mind is the toxicity rate between the 2 arms. So the addition of ipilimumab to nivolumab resulted in a toxicity, grade 3 toxicity rate of 29.7% versus 14.7% in the control arm. So you are seeing more toxicity. And I think one of the big things that we want to keep in mind with this patient population receiving dual checkpoint inhibitors is that we don't have any predictive biomarkers for those who will receive or develop, one of the very rare but potentially fatal toxicities like myocarditis or lifelong toxicities like type 1 diabetes. So without those predictive biomarkers, it does make it challenging. And there needs to be a huge risk benefit conversation with these patients about what we understand with immunotherapy toxicities and what we could potentially be causing in terms of toxicity when we give this regimen to patients. But overall, this is incredibly exciting for the field of melanoma.
Awesome. Those are some really impressive results. So thanks so much for explaining it and for sharing the considerations for toxicity as well. Looking ahead a little bit, how can this trial also be applicable beyond melanoma in the future?
Yeah, so I think this is, and this was discussed at the plenary session. This is a prototype for other malignancies. So giving dual checkpoint inhibitors or even single agent checkpoint inhibitors in the neoadjuvant setting for other diseases, showing that we can achieve major pathological response and essentially spare people needing adjuvant therapy is a huge advancement that was demonstrated in this clinical trial. So the concept of using dual checkpoint inhibitors before surgical resection and other tumor types is now has some significant phase 3 data to support that rationale. But again, just as we've seen in the metastatic setting, we don't have predictive biomarkers for toxicities. We don't have any way of sitting with a patient in clinic and saying, I think your chances of developing myocarditis are exponentially higher than other patients. And I think it's maybe the risk is too high for you. We use some things like past history of autoimmune toxicities. We use, performance status, which is, much more applicable in cytotoxic chemotherapy, but can give us some type of, rationale for if, someone doesn't have the reserve to develop toxicity, it could be very life-threatening or dangerous to them. But in a lot of ways, it's both exciting and a little bit scary in that we don't know who's going to develop these toxicities, and that's something that we have to keep in mind as we start giving more and more of these in the metastatic setting, in the neoadjuvant setting, because whereas in the metastatic setting we're treating patients who have unfortunately incurable disease, and the risk is oftentimes very much outweighed with the benefit of what we could offer with these therapies. When we're talking about curable disease in the earlier phase or earlier stage of disease in the neoadjuvant and adjuvant settings, and cancers that may be, hopefully curable with very low recurrence rates with what we're doing right now in terms of SWOG 1801, it really does bring up a lot of questions. And I think it's a very exciting time for immunotherapy in general and very exciting time for patients, but we have to be very cognizant of how we balance these advancements with the potential toxicities to the patient.
Absolutely, definitely very important to keep in mind. Great. As we wrap up, anything else you'd like to mention about the trial and its significance for the melanoma community?
I think it's a very exciting trial. It's in a very long lineage of learning more about immunotherapy and how the concept of giving immunotherapy while a tumor is still intact and priming the immune system to hopefully have this long T-cell response. It's very, very exciting. And I think if a patient is diagnosed with melanoma, stage 2, stage 3 melanoma, this is a stage 3 trial, or it's for the treatment of macroscopic stage 3 disease. But if you're a patient diagnosed with stage 2 melanoma, we're also giving immunotherapy or recommending it in the adjuvant setting. So I only say that to just say that if you're a patient diagnosed with melanoma, these are the trials that you should be bringing up to your oncologist to make sure that these conversations are having with them, because there is a lot of new treatment options and it's changing very quickly, and it's important for patients and physicians to be really informed about that.
Absolutely. Well, thank you so much for coming on today to tell us about this trial. It's definitely very encouraging to hear these results, and looking forward to hearing more about it in the future as well.
Awesome. Thank you so much.